All right. We are here today with Dr. Jody Russon. Is it Russon or Russon?
Russon.
Oh, thank you. Russon. Um, she's going to talk to us today about attachment-based family therapy. And in particular, we're hoping to talk about how it applies to LGBTQ youth. So Jody, you want to introduce us a bit to where you're from and how you got here?
Katie, thank you for having me. I am Dr. Jody Russon. I am a trainer, supervisor, and certified therapist in an approach called attachment-based family therapy. It's an approach developed by Guy Diamond, Gary Diamond, and Suzanne Levy to treat depressed and suicidal adolescents. I am also a family therapist and approved supervisor. I work currently, I'm an assistant professor at Virginia Tech, Marriage and Family Therapy doctoral program in Virginia. And so I'm looking forward to speaking with you today about attachment-based family therapy and specifically ABFT, which is the abbreviated form of attachment-based family therapy. I'll use those acronyms with you. I'll be speaking with you about that throughout our time.
Yeah, thank you for defining that. Sometimes I just go off and say ABFT, and then I realize nobody but me knows what we're talking about.
That is exactly what I wanted to say. If I say ABFT, I'm talking about attachment-based family therapy.
Wonderful. So I'm wondering if we can start by just sort of broadly defining, what that attachment-based family therapy, sort of what that means about the model and kind of how you're understanding adolescent depression and suicidality within that kind of a framework.
Yeah, so that is a great question. When we think about adolescent suicide and depression, we really think about it as an interpersonal issue, a relationship issue, concerned about the quality of that relationships. Now, something to know about the field is that there are very few treatments for adolescent depression and suicidality, and particularly suicidality. And even fewer of those treatments involve family members and involve caregivers in that work. And then even fewer of those really see the family as the primary mechanism for change or the way that change can happen in a family. In ABFT, we see the change in the suicidality being dependent on the quality of the parent-child or caregiver-child relationship. We ask ourselves what gets in the way of the kid turning to the caregiver for support when they do feel distressed or suicidal. And it's that problem in reaching out for help and the caregiver being able to respond to provide help that is actually the issue that we're looking at here in this therapy.
Yeah. And in that way, it's very different than most approaches to like a diagnosis of depression, right? Where we think of it as it's your problem, you feel that way. And we don't take into account how that experience of depression is related to the people around us and the way they respond to us when we're feeling distressed or we're feeling sad. If I'm following kind of what you're saying there, that it's about who we turn towards and if they turn towards us.
Absolutely, absolutely. And it's so important that you say this, who do we turn to and who turns towards us? Because our very first session in this type of approach after we do the assessment is to help the family see this. Mm-hmm. So it's not enough for us to walk into the door as therapists and think about relationships and the impact. We want to have the family join with us in this type of thinking so they can start to look at themselves and their relationships and being part of the team to take care of this issue. And we can talk more about the mechanics of that later on.
Yeah, that one of I know you guys call them tasks, sort of those things you need to have happen that are sort of markers for you that change is happening, is occurring. And it sounds like that's one of the important ones, that sort of turning towards.
Yes. So in ABFT, there's 5 different tasks. And in this model, we don't think about tasks like you would in typical manuals. We don't have a script on what to say and what to do. In this model, the idea is that you are following a set of processes that give you guidance, a roadmap If the developers were here, they would say, this is a roadmap for you to go in the direction you want to go on a journey. And it's not scripted. And so these tasks are really like processes instead of concrete, fixed to-do lists. And so we want to be mindful when we talk about the 5 different tasks that we're really talking about what we want to see happen for the family and for the caregivers and for the youth emotionally, interpersonally, and cognitively.
Mm-hmm. Mm-hmm. Yeah. So it's not, I mean, where my mind went when you were talking was like homework assignments. It's not, it's not that. It's more like markers along the way.
Right. It's a process-oriented, emotion-focused therapy where we're attuned to what's happening between people in the room, as well as what's happening within people, psychologically, emotionally, cognitively.
Okay. Okay. So, so if the idea is we need to, you know, essentially sort of get families to turn towards each other in these moments, what have you noticed about, in terms of that process becomes common barriers between an adolescent and a parent?
Yeah. So we see a lot of barriers, and let me just focus in on the relational reframe. The relational reframe is that task 1. That's what we do when we start the therapy. The goal of task 1 is to punctuate what is getting in the way. Now, we work with a lot of kids who say, I feel like I'm a burden whenever I turn to my parent. My parent panics and they're actually not helpful to me when I need their help.
Yeah.
My mom or dad or a grandma or sister didn't trust me when I needed help before, and how can I turn to them again? Um, my parent is critical of me. They don't understand who I am. These are all things we hear when in our task 1 session, after we've gotten to know the family, we ask, kid, when you are in so much pain, what stops you from going to dad?
Right.
And kids can answer that and they can give us the answers I said, or sometimes kids don't know. They
Yeah.
just know that there's a rupture or a breach there that they can't identify. And that's okay with us at first. We say it's enough to know that when you are in your deepest, darkest moment, that you are not turning to your caregiver.
Mm-hmm.
What is the impact of that?
Right.
And then later on, we might flesh out what exactly is happening and what the dynamics are. But it's most meaningful to us in that first session to know that the kid is actually not going.
Mm-hmm. Mm-hmm. What's your experience? I'm that relational reframe where the depression or suicidality moves from a kid problem, you know, the adolescent has that, it's theirs, the depression or the suicidal feelings, to a relational or family problem. We're all sort of a part of this in some way. And so when I hear you talk, I hear you sort of trying to move the conversation of like, the depression is here because of this process between the two of you, not necessarily something inherently problematic about the child themselves.
Yeah,
Is that fair?
absolutely. This is your family's problem. I don't think they would be with me if I did that.
I
So
don't think so.
so what ABFT does is it breaks it down. We start by acknowledging kid is in here because he hasn't gotten out of bed in a week. He's depressed.
Mm-hmm.
What does the depression look like? Kid, parent, what does it look like? Why are we coming in?
Right, right.
Then when things start to change is when we start to focus on that depression. We start to expand it. We really start to get the kid's experience. Maybe kid doesn't see that he's depressed, but maybe he's been bullied at school so severely that the fear is not letting him get out of bed in the morning.
Right.
And we try to uncover some of that context, that emotion, and then we have the data or the content to say when you are really struggling here and when the kid is on record of feeling upset, what gets in the way at that point? So that is our process of getting kid and parent buy-in so that we can ask that question. Kid, you're in pain. Parents, you're confused. Well, what's in the middle here? So we set them up for that conversation, because without the setup, I don't think they could go with us.
Yeah, they have to kind of buy into this other way of seeing it. And for the parents to feel like I'm a part of this, like not in a it's all your fault kind of way, but in a you could make a difference kind of way.
Absolutely. And that's where we want them to be at the end is, wow, I didn't know my kid wasn't coming to me.
Mm,
I didn't realize that. It makes me feel helpless. It makes me feel overwhelmed. Sometimes we get anger at the surface of this, but when we get underneath, there's a lot of hopelessness and helplessness.
yeah, I'm glad you said that because I know I've definitely seen parents who I've worked with where the initial reaction is sort of anger and frustration. And well, if they would have told me, I would have done something. Sometimes maybe some defensiveness right around that, or my kid is always snarky with me. They never tell me the truth. You know, there's like lots of reasons they have for not knowing, but like underneath that is if you maybe the goal it sounds like is to get underneath that some with them and identify those other feelings that might be happening.
Yeah. Oh, yeah. You know, I've had parents who have been furious. Their kid is out all night on the street. They don't know where they are, and they're pretty mad at their kid in the room. And part of my job as the therapist is to unpack that. Of course you are mad. Of course you are furious. You are up at 2 o'clock looking for your kid on the streets. You must have been terrified
Right.
that something would have happened. They're not in touch with the fear. The anger is what comes through, but the kid needs to see that fear.
Yeah. Yeah, they need to see that more vulnerable place, the less parental sounding place, I imagine. Um, so they can see there's I sometimes you know, I remember being an adolescent and like not seeing my parents as humans, but like bad guys, you know, like they're kind of like they're not in my corner or they're always going to say no. I'm thinking through some of the things I used to say. Um,
Yeah,
and partly because I didn't see a lot of those soft spots. I didn't see a lot of the scared or the sadness or the helplessness they felt. I mostly saw the attempts to discipline me, you know, the attempts to sort of become parental in some way. I imagine that's a familiar scenario for you.
it's absolutely familiar. And part of the fact of ABFT is oftentimes kids can't respond to that structure, that discipline when trust has been broken. And so if we don't repair that trust, when the parent comes in and says, no, you cannot go out at 2 o'clock in the morning, there's not the trust there for the kid to really see the good intentions behind that.
Yeah, yeah, to say mom and dad are looking out for me,
Yeah.
but instead they're just mean. They don't care about what I want.
They
So
don't see me, they don't understand me, they don't accept me. Yeah.
mhm. Yeah, that makes a lot of sense. So as the tasks go on, I mean, I know this, but folks out there don't know this. There's tasks specific to the parent and then specific to the youth. And so it's family therapy, but based on some of the tasks, it sounds like there's some time with just parent and some time with just kiddo. If you could talk through a bit about like the purposes of those as well for the process.
Sure. So in attachment-based family therapy, we do work with what we call the subsystems. After that task one, that relational reframe where we get the family's buy-in, let's work on the relationship first. This is something that we want to get everybody on the team with. Once we do that, we work with the caregivers individually and the youth individually. We call that the youth alliance task and the caregiver alliance task.
Mhm.
And we do that work with them to try to help understand where each of them are coming from and to get at the specifics of the attachment landscape between the kid and the parent. As I said in the beginning, in a lot of therapies, we pay a lot of attention to just what goes on between, and a lot of therapies pay attention to just what goes on within. And in ABFT, we want both. And so these tasks give us an opportunity to understand what's going on intrapsychically. And particularly for caregivers who often come from their own backgrounds of trauma or neglect, or ruptures, often not dissimilar to what their kid has experienced. We want to help them be able to get in touch with that and be able to use it to help motivate them to be different now. And so these independent tasks are really, really important, before we can come back together and make real family change happen.
That they begin to have some understanding about themselves to then bring into the room and feel ready maybe to say the things they need to say.
That's right. That's right. Because how is the kid going to walk in and tell their parents, look, I don't trust you anymore because you didn't believe me when I was being abused, or whatever that example is? Kids need help and coaching and insight and reflection to be able to get to that point where they can turn and say that. And also, we couldn't have them turn and say that if we didn't have the parents do their homework and be prepared to hear that with open arms, because it wouldn't have been safe for the kid to say that before if they didn't have some kind of trust in our approach to help the parents listen. And so when we call these tasks alliance tasks, that's absolutely what we're doing. We're putting ourselves in the position where we can be what we call in attachment terms the secure base for both the caregiver and both the kids, so they can do exactly what you said.
Yeah, and this is all done by one therapist who does both. Because the other thing I see out in the practice world is sometimes we split this up. We have like the family therapist, the individual therapist, the couple therapist, maybe if we're really having fun. And it gets really split up, and that's supposed to be the ethical way. Well, people argue it's the ethical way, so that we're not biased or whatever the reason might be. Can you talk a little bit about why that having sort of one core therapist is, and maybe you've already kind of said why, but why that's part of the model?
Yeah, so a couple different things. First of all, in the family therapy world, this concept of multi-directional partiality. I know it's a mouthful, but I love that word. It connects us as the therapist. It means that we can be aligned and supportive of multiple people at once, and we have to have that. And so ABFT is an effort in this multi-directional partiality. And it's necessary because if we are going to be the shuttle diplomats, as the developers would say here, if we are going to use shuttle diplomacy in between kids and parents to facilitate repair, we better know what's going on for the other person and what the triggers are, because that's what's going to help us attend to everybody equally. Now, this isn't to say that we've certainly worked with kids who can benefit from their own therapists in addition, some CBT work, or some more specified work on the side or after. But to do ABFT and to really tackle the relational issues, we need to have a hub or a center. And so it's helpful to maintain that stance of multi-directional partiality and work with the entire family.
Yeah, that's actually one of my favorite concepts too. And I agree, it's a mouthful, but I think it really changes how you see things then, or this idea that as a therapist, I can't maintain um, some kind of secure base from multiple people. When in reality, even if you're seeing one person with multi-directional partiality, it has an impact on lots of other people in their lives. And so you can either engage those other people or not, but either way, the impact might be the same. And so there's a responsibility there almost, it sounds like.
Absolutely. There's a responsibility, and something we talk more about in our trainings is how we navigate confidentiality and the very explicit conversations we have with both kids and parents. Because if you are going to work with multiple family members, as you say, there's an added responsibility, and we need to be transparent. And so that we think a lot about these things in ABFT, because really these families come to us trusting us to help make repairs in their relationship. And our transparency and forthrightness with them does a lot to help with that.
Yeah, yeah. So, I will get more into that when you come and do some training here in Missouri, which I'm very excited about. But I also want to make sure we get to talking about, you've worked with LGBTQ youth and their parents in particular, and with this model, and I know you're working out some modifications that might need to be used in that group. And so I'm wondering if you can talk a little bit about that experience and research that you've done, and how you've seen this model fit in those families as well.
Sure, sure. So a little bit of history behind this. Back in 2012, our colleague Gary Diamond, who is one of the developers of the approach, did a pilot study where he specifically adapted this model for LGB, lesbian, gay, and bisexual youth um, at the center in Philadelphia. And so he came up with a set of modifications specifically for sexual minority youth. My work has been about bringing ABFT into the context of LGBTQ plus community centers. So how do they work? How does this model work within those systems where youth are more likely to go? What I had found in my work is that oftentimes a lot of my referrals for suicidality came from providers who were referring trans youth in particular. And so as a result, we've been working on modifications for trans youth and gender diverse youth, and really are seeing how those modifications or adaptations look different for trans youth than they do for sexual minority LGB youth. And even further, to make it more complicated, because clinical work is always complicated, there is a difference in the way we work with families based on their level of rejecting behaviors versus accepting behaviors. We work with families a very different way if their caregivers come in knowing about their identities, and if they're accepting or at least tolerant than if they're rejecting. And so there's a lot of nuances in this work. And our adaptations are really aimed to reflect some of these nuances and help clinicians with the judgment calls they make when working with these families. But what I can say overall is that we have found in our work thus far that the mechanism of ABFT, that focus on the caregiver-child relationship, remains central and influential with LGBTQ plus youth, but it's the mechanics of the way that we operate the model that needs to shift to work better for these families.
Yeah, to attend to that difference, it sounds like, in terms of parent, I mean, rejecting behaviors run the gamut, you know. I mean, I know you know this, from off comments or silence, right, to abuse and violence. And so depending on where we're at on that continuum, and maybe how open a particular parent is to moving along that continuum in a particular direction, it sounds like that might shift a little bit. Because I have to imagine, like, the question I get a lot, and maybe you get this one too, is you're asking me to tell a child to trust their parent when they're not safe. Right. And when they say safe, they mean that around having an affirming or accepting attitude towards their sexual or gender identity. Right. So I'm curious how you answer that, or what you say when that comes up.
Yeah. So I think that's where the work begins, right? That's where we enter the picture in task 2. Now I've worked with some LGBTQ plus youth where we cannot have a task 1. Things are so challenging. And remember that task 1 is the relational reframe. We always push for a relational reframe because it's that contract, it's that motivation, it's that framework shift where we get everyone on the same team. But for kids who have parents with persistent rejecting behaviors that come into me and say what they said to you, we explore it and we try for a task 1 and it's not happening, we start there in task 2, the Adolescent Alliance. And so my message is, you're right. Things have felt really unsafe to you. Your parent has not accepted who you are. What do they do to show you that?
Mhm.
I get really specific about the behaviors, what the caregivers are doing, because it's my hope that this kid will allow me, even if they can't sit in the room with their caregiver, that they would let me sit in the room with their caregiver. And we can start unpacking where this behavior is coming from, helping the caregiver get awareness around how their own fear, discomfort is creating some really hurtful situations for their kid that they may not be aware of. And so it's really important when we're first starting with families not to get too steeped in the ideology. They accept me versus they don't accept me. They believe in LGBTQ issues or they don't, but really look at the behaviors to start.
Right.
And that initiates the process of being self-reflective.
Yeah, you're making me think of something I heard someone say a long time ago in some great training I went to. And I can never quote the person, but they said something like, I'm not going to get an argument with somebody in therapy about their belief system, but I will talk about impact of behavior, right? I will break down the behavioral process between them and other people that is hurtful or painful, right? And that's something there, that's a place to talk and grow from. I don't know about those other things. Maybe as a result of changing behavior, it'll change back there, but this is a place to start. Is that similar to what you're saying here?
That's absolutely similar. And if we, if we don't start somewhere, we're doing a disservice to these families. If we don't engage the caregiver, we send a kid home to a rejecting, hurtful environment.
Mhm.
So I think we have to tolerate that to some extent as therapists. Our the attempt to bring caregivers in. And I realize how hard this is. I mean, I'm an LGBTQ plus ally, and I work with a lot of allies and those who identify as LGBTQ plus, and to sit with caregivers who are really struggling with this is incredibly difficult. It brings up what we call person of the therapist issues. They come to the surface. Um, but we have to realize too that if we're not in the room working with that caregiver and the kid is deeply impacted by that caregiver, whether they live with them or not,
Mhm.
we're missing an opportunity.
Right. Yeah, I say something very similar to my students generally about family therapy. Like, you're sending this person home to that partner or that parent. Um, so why not engage them? Like, you're not saving them by not bringing in that person. And it sounds like from an ABFT perspective, it doesn't mean um, maybe initially you would do a lot of family sessions as you're sort of working through some of those really painful places or the struggle that the parents having or the kids having to be in the room together. But it doesn't mean you necessarily go, well, we can't do anything, so I guess it's just this way. But you stay engaged in a way that maybe hope at some point they'll be able to come back together.
And you're so right, because I kid you not, I have been humbled by the processes that have taken place in front of me in task 4. I have gone in and I have felt like a caregiver hasn't shifted at all. They haven't changed their ideas. They haven't, belief that LGBTQ identities, it's a sin, have not changed that. But they change one thing. They start listening to their kid. Yeah, I can see that I was being a jerk there, mom says.
Mhm.
Not soft, not sensitive. It means everything to the kid. And so that reminds me too, sometimes it's not about me. I mean, it shouldn't be about me, but it's not about what is right for me. It's about what's right for this kid and what this kid sees as engaged and supportive and caring.
Right, right, right.
And and again, I've been humbled by that.
Yeah, and it might look different in each family, and so it seems like again in that way they're tasked, but you're not sort of. It's not like you're trying to get them to put on a play that has to look exactly the same way. It's like this task will look this way for this family given their cultural background, or maybe I always love like family culture where every family is a little bit different. You get the sarcastic families, you got the angry family, whatever. But it'll look like how it looks like for them. And you just have to be ready to sort of receive that and honor it for what it is, and that works for them.
Yeah, yeah. We all work with real families here. There's no cookie cutter shapes, and with our LGBTQ plus youth, I mean, we live in a society that can be pretty pathologizing and dismissive and hurtful, and so we're compounded by these factors, and a lot of our families. Come by this hurt in real ways. A lot of the parents I work with who are at first very rejecting or engaging in rejecting behaviors are scared to death that their kid isn't going to be accepted, that they're going to be beat up on the train, that they won't survive in this society. It's out of love for their kid, but it comes across as very condemning and rejecting.
Yeah. Yeah. And, what we talked about earlier, like that's harder for a kid to see the love, because as parents, I'm a parent, you tend to lead with the fear, or the fear brings out anger or frustration or some hardness as we're trying to keep you safe. It's like grabbing your kid when they, are running in the street. But the kid feels pain, right? They feel you pull their arm back. And so, if we don't slow down enough as parents to understand what else is there, the kid misses actually the message that maybe we're trying to convey.
Oh, totally. And I had a kid who um, mom and dad were very affirming, parents very affirming. Their kid identified as a trans boy, but gender fluid, and he wanted to wear a skirt to school one day. He wanted to do that, and he got up and he was wearing a skirt and he was all ready to go, and dad says, "You need to take that off right now."
Mm.
And when we unpacked it, it wasn't dad saying it's not okay that you're expressing yourself in this way. Dad was scared that kid wasn't gonna do well on the train, that he would be attacked, and that didn't come through. That didn't come through. But once we were able to unpack this and the family could see a different part of their response, then we got somewhere. And that's what the mechanics of ABFT try to do. We're heavily influenced by narrative approaches, and it's about the kids' narrative and the parents' narrative, and helping them to really understand and sit in their attachment views about themselves and what they think is happening, and letting that be challenged by the interpersonal process.
Yeah. And so to your story, I'm imagining sort of being surprised. I imagine the kid was surprised to hear dad say, I was scared for you, because he probably was like, you were being judgmental, or you were restricting my expressiveness, those things. And so it being open to the surprise of that, to hearing the parent's version of the story, and for the parent to hear the kid's version of how painful that was. And then it sounds like an openness to believe both of those.
Yes, and we set it up so the kid does this first.
Mhm.
That's the remaining task. So task 4 is the attachment task. And in that session, we don't want parents explaining anything at that stage in the game. We want them to be fully supportive of their kid. And then at the end, they might come in and say, I get that this was hurtful, and I was also really worried. And they explain that. But we find that if we can offer kids that space to really process with the parents what's happening, that is a corrective experience. It's hard to do, it's different for families,
Mhm.
but it is necessary that the kid comes forward first
Yeah.
before the parents.
You're making me think of that old family therapy concept, the asymmetrical mandate. I think it's from contextual or structural, one of those two. But that idea that the responsibility lands on the parent first to receive the child, if I'm hearing you, and for the child to feel listened to, cared for, believed. And then after that, the parent might get a shot, but kid first, because the adult in the room needs to show up as the adult in the room. Is that fair?
That's absolutely fair. ABFT is a developmental model where we're highly influenced by structural family therapy. That's what sets us apart from EFFT, which is emotionally focused family therapy. We believe in establishing the hierarchy in the family and getting the parents in a position where they can scaffold their kid. That's a big part of the work that we do. And so, yeah, that the kid does come first. We do empower the parents to step up first, and then later we have more collaborative discussions, but we start there.
Yeah. Yeah. I mean, as a parent, that's resonating with me. I mean, as a therapist, that is too, because you can't ask the kid to do something the parent hasn't done yet, right? It's sort of like if we're modeling good relationships, healthy relationships, then we model by first being the one who shows them how to do it, right? How to be empathic, how to listen, how to understand. That's how we do everything else. Like, why wouldn't we do it here? So we have just a couple of minutes left. I wonder if there's anything we haven't touched on yet that that you think is important about the model, or would help give a bit more introduction, or have we covered kind of the main parts of it here?
Sure. One last thing I will say about the model is that, and we'll touch on this a lot more in the training, but task 5, that's what happens after task 4. That's the autonomy promoting task. We believe in ABFT that task 5 is where life happens. That's when kid gets back into art, thinks about the future, talks about issues of identity. It's where a lot of our trans youth talk about options, HRT, other ways to move their life forward. We start with tasks 1 through 4 because we believe we cannot get to that autonomy promoting without the secure base of the relationship. And indeed, a lot of the parents of trans youth that I work with won't even allow their kid to start some of these autonomy promoting tasks, especially when we think about physical transition, until we get some kind of relationship established and trust rebuilt. And so, again, if the developers were here, they would say, we do tasks 1 through 4 to get to task 5.
Speaking of autonomy, this one, very autonomous. That makes a lot of sense to me, right? Like from attachment theory, but also when you think about, I remember like Bowlby's first work, and like the babies who are most securely attached could go explore. So I had to know my caregiver was there the way this one does, so that they can then run off. I'm gonna run off. So they can then run off and go find out for themselves what they enjoy, what they don't enjoy. But until they feel like they can come back to their caregiver, it's just scary. It's just all scary.
Exactly. And we would argue that proximity seeking, like what we're seeing right here, is relevant even in adolescence. And as you said, that makes kids feel safe to explore, to expand, to really get bigger in who they are and who they want to be. And so that, again, that is where life happens in this moment.
Yeah, that makes so much sense. Well, I am so excited for your training to come.
I'm so excited to come as well. Thank you for having us.
Yeah, I think it will be fun. And I'm glad too that we get to focus some in on that work with LGBTQ youth, given, how we know they are disproportionately affected by that kind of rejection, and certainly show up in our offices more often than not.
Exactly. Yes.
That's wonderful. Well, thank you so much for talking with me today.
Absolutely.